Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host Nykki, who handles the headlines. Take it away, Nykki.
Thanks, Tony. We've got a dense one today, 3 papers, 3 very different corners of menopause research, and at least one finding that genuinely frustrated me. Let's get into it. The first study comes out of 2026, published on PubMed, lead author Song Zhe. The title is a mouthful: Dietary Quality, Insulin Resistance, and Preserved Ratio Impaired Spirometry in Postmenopausal Women. So let me translate that, because once you know what spirometry means and what PRISm is, this actually gets interesting. Spirometry is a breathing test. You blow into a tube as hard and fast as you can, and clinicians measure how much air you move and how fast. Most people know about obstructive lung disease, asthma, COPD, where the airways are narrowed and airflow is limited. But there's another pattern called PRISm, Preserved Ratio Impaired Spirometry. In PRISm, the ratio between your total lung capacity and how fast you can exhale looks normal, but your absolute lung volumes are reduced. You're moving less air overall, even though the proportions look fine on the surface. It's subtler and it tends to get missed. What this study found in a cross-sectional sample of postmenopausal women is that lower dietary quality was associated with higher rates of PRISm. And when they ran a mediation analysis, insulin resistance appeared to be part of the pathway connecting diet to that lung impairment. Now, I want to be careful here, because this is exactly the kind of finding that gets oversimplified into bad diet causes lung damage. That's not what this study shows. It's cross-sectional, meaning everyone was measured at one point in time. You cannot establish direction from that. You can't tell whether poor diet is driving insulin resistance, which is driving lung changes, or whether something else, baseline inflammation, body composition, socioeconomic factors, is doing the heavy lifting, and diet quality is just travelling alongside it. The mediation analysis is exploratory, which the authors flag themselves. This study is generating a hypothesis, not confirming one. What it does do is add postmenopausal women to a conversation that usually centres on smokers and older men when we talk about lung function decline. Estrogen has receptors in lung tissue. There are mechanistic reasons to think menopause changes pulmonary physiology, and insulin resistance, which spikes in the menopause transition, could plausibly be a mediator. That's worth studying properly in a longitudinal design, with enough women and enough follow-up time to actually test causation. This study is a reasonable first step toward asking that question. It's not the answer. The practical upshot, if there is one right now, is less about lungs specifically and more about insulin resistance as a whole. Research on insulin resistance in postmenopausal women is consistently pointing in the same direction across multiple organ systems: metabolic, cardiovascular, now possibly pulmonary. Diet quality, higher fibre, less ultra-processed food, lower glycemic load is one of the more robustly supported levers for improving insulin sensitivity. That's not new information, but it's worth noting that the downstream effects of insulin resistance post-menopause may be broader than most people realise, lungs included. The second paper is where I'm going to spend more time, because it touches something that has needed direct attention for a while. The paper is from Lapin JM, published August 11th, 2026, and the title is Midlife Women Miss Out. RANSI-CP treatment guidelines for schizophrenia should consider the life stage needs of midlife women. RANSI-CP is the Royal Australian and New Zealand College of Psychiatrists. Their treatment guidelines are a significant reference point for psychiatric practice in the region. The argument the authors are making is pointed and frankly well documented. Current guidelines for treating schizophrenia don't meaningfully account for what happens to women when they hit perimenopause and menopause. And that matters enormously because menopause changes everything about how antipsychotic medications work in the body. Here's the clinical reality. Estrogen is neuroactive. It modulates dopamine receptor sensitivity, and antipsychotics work primarily on dopamine pathways. When estrogen drops in the menopause transition, women who have been stable on a given antipsychotic dose for years can suddenly find that dose is no longer adequate. Symptoms can re-emerge or worsen, not because the medication stopped working, but because the neurochemical environment it's operating in has shifted. At the same time, lower estrogen also changes how drugs are metabolized and how sensitive women are to side effects like tardive dyskinesia, involuntary movement disorders that are already more common in women than men on antipsychotics. What the guidelines apparently don't do is give clinicians specific guidance for adjusting treatment at this life stage. There's no clear framework for recognizing that a woman's worsening symptoms at 48 or 51 might be a hormonal transition issue, not a medication failure or a disease progression. And without that framework, clinicians are flying without instruments. This is a medical system problem, not an individual clinician problem. Guidelines exist precisely because no single doctor can hold every variable in their head for every patient. When the guidelines don't build in life stage considerations. For women, the absence gets replicated across every practice that follows them. Midlife women with serious mental illness, already a population facing significant stigma and access barriers, end up with one more layer of clinical neglect baked into the system. The authors are calling for guideline revision. That's the right ask. Whether the RANDS ACP moves on it quickly is a different question. Guideline revision is slow, consensus-driven, politically complicated. But naming the gap publicly in a peer-reviewed journal is how pressure gets applied. This paper is doing useful work. I'd add, the principle here isn't specific to schizophrenia. Across psychiatric conditions, depression, bipolar disorder, anxiety, the menopause transition is a period of biological vulnerability that most treatment guidelines treat as invisible. Schizophrenia is the focus of this paper, but the argument extends further. The third paper is a different beast entirely, and I want to be upfront about what it is and what it isn't. Zhong Wei and colleagues published August 20th, 2026, looked at a traditional Chinese herbal formula called Chai Hu Shu Gan San. The study examined how this formula affects microglial polarization and hippocampal synaptic plasticity in mice modelled for menopausal syndrome with liver key stagnation, which is a TCM diagnostic category. Let me pull that apart. Microglia are the immune cells of the brain. When they're activated in a pro-inflammatory state, what's called M1 polarization, they can damage surrounding neurons and disrupt synaptic connections. The hippocampus is central to memory formation and spatial reasoning. In mouse models of menopause, there's evidence of increased neuroinflammation and disrupted synaptic plasticity, which maps loosely onto the cognitive complaints, memory lapses, word retrieval issues, difficulty concentrating that a substantial number of women report in perimenopause. What this study found is that Chai Hu Shugan San appears to reduce microglial M1 polarization through a specific molecular pathway, C3-C3AR signaling, and that this was associated with improved markers of hippocampal function in the mice. That's genuinely interesting mechanistically. The neuroinflammation angle in menopausal cognitive symptoms is a real area of active research, and identifying specific pathways that might be modifiable is exactly the kind of basic science that can eventually lead somewhere useful. But mice. These are mice. Mouse models of menopause don't map neatly onto human menopause. The timescales are different, the hormonal dynamics aren't identical, the brain architecture diverges in important ways, and the leap from this modulated a pathway in mice to this herb improves memory in perimenopausal women is enormous. Most compounds that look promising in animal models don't survive the translation to human trials. That's not pessimism, it's the base rate. Chai-Hu Shugan-san has a long history in TCM practice, and there's a modest clinical literature on it for mood and cognitive symptoms, mostly small trials, variable methodology, largely out of China. This mouse study adds a plausible mechanism to that existing picture, which is useful. It's not proof of efficacy in humans. It's a reason to design better human trials. If someone is already working with a practitioner knowledgeable in traditional Chinese medicine, and Chai-Hu Shugan-san comes up, this study adds some biological plausibility to the conversation. If someone is thinking about buying a supplement because they read a headline saying, Chinese herb improves menopausal brain, that's getting way ahead of what the evidence supports. The distance between a mouse study and a supplement claim is where a lot of wellness grift lives. The brain inflammation question itself, whether neuroinflammation is a meaningful driver of menopausal cognitive symptoms and whether it's modifiable, is one of the more compelling open questions in this space right now. I'll be watching how this area develops, because if better designed human trials start to emerge, that's a conversation worth having properly.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.